My name's Anita. I'm one of the third-year residents, and Dr. Freed and I talked about this topic, stress ulcer prophylaxis in critically ill patients, because this is something that essentially everybody that is admitted to the ICU is put on, and I don't think that we do a good enough job of understanding whether or not there's evidence behind putting every patient on prophylaxis. So the myth that we are looking into today is stress ulcer prophylaxis should be given to all critically ill patients. The objectives, just a little bit of history, some background on stress ulcers, the physiology of the gut, the pathophysiology and pathogenesis of stress ulcers and how that's a little bit different than a different type of ulcer. And then the history of stress ulcer prophylaxis, and can we prove or disprove this myth? The stress ulcers were actually made famous by Thomas Blizzard Curling. He was a British surgeon in the 1800s. He documented, I think, 10 or 11 cases of these ulcers in his critically ill patients and described these gastric mucosal lesions that he was seeing, particularly in burn patients. So they started calling these curling ulcers. Dr. Thomas Curling was kind of first associated with this. So how common is it? So by literature review, it cites several different numbers, but basically 75 to 100% prevalence of this mucosal injury in critically ill patients. That's using endoscopic studies. Now, the actual amount of significant bleeding is really only 1.5%. And we'll go into a couple of these studies later that I'm mentioning. But the frequency of the ulcer itself is quite low, as you can see. So, what is it about the gut that we need to preserve to prevent bleeding? So the gut has several mucosal defense strategies. On the right side, you can see the mucosal cells. So those are regenerating at a pretty rapid speed, so you actually get healing quite quickly of any erosions. But if you have degeneration of the mucosal layer, which is this blue on top of the cell layer, this mucus layer actually has what they call an alkaline tide. So it's secreting bicarbonate into this layer, and it's actually protecting the mucosa. So you have cell regeneration and you have mucus and this bicarb layer. Also, you've got the microcirculation and a number of cytokines and prostaglandins that kind of help keep the gut healthy. So the reason why we think we get these gastric mucosal lesions in these particular patients that are very sick are basically based off of three main mechanisms, we'll say. So the first two being ischemia and oxidative stress, which sort of go hand in hand, and we'll talk about that. And then the other being the presence of a low pH and gastric acid. And we'll also talk about why that's important. So first thing I want to just mention is the splanchnic ischemia that's been studied. So all of these studies are basically done on rat models. So these aren't human studies that are correlating this, but in rats, they did show a linear correlation between systemic blood pressure and the gastric or splanchnic blood pressure. So what that meant was if your systemic blood pressure decreased and you had hypotension, you were likely to get a linear correlation in the gut as well. So it's not like our kidneys, it's not having any autoregulation to preserve blood flow. So you can get, what they found was these rats, when they induced systemic hypotension, were getting mucosal lesions in the gastric tissue. And these lesions happen when your MAP was about less than 40% of your baseline blood pressure. When I say you, I mean rats. So the reperfusion, not just the ischemic injury, but then they also noticed reperfusion injury, which is what we've seen in several other organs in the body. But in addition to that, on certain rats, they decided to add a certain amount of acid to the stomach. So what they noticed was a dose-dependent increase in the size of these lesions that were caused by the ischemia. And these numbers that I wanted to highlight here was if they didn't have any acid added, so just the rat gut, whatever acid was produced at baseline, the injury caused by ischemia was about 3 or 4% of the gastric body surface area. But if you add acid, that went up to 45, 53% of the gastric surface area. So it's a big increase in the size of the lesion, and obviously you can imagine that could increase your risk of bleeding substantially. So the next one I just want to mention briefly is oxidative stress, and this does go hand in hand with the ischemia, because ischemia and hypoxia increase these pro-inflammatory pathways. So we're talking about nitric oxide, cytokines, these adhesion molecules. Nitric oxide, as we've seen in other organ systems, plays an important role, and especially in the gastric defense. This picture is kind of showing you all the different ways that it actually interacts in the gut. So it interacts in the endothelium to increase mucus secretion. In neutrophils, it's reducing the adherence and the secretion of the neutrophils to the gut wall. Oxidative stress, obviously you can get this cascade where the nitric oxide becomes INOS and is a oxidative stress to the body. Fibroblasts, musculature, angiogenesis, macrophages, mast cells, these are all involved with nitric oxide, so it does play a very important part. And I just want to take 1 second to talk about the history of the stress ulcer prophylaxis and what we've done historically as physicians. So in 1978, there was a study that mentioned hourly titration of antacids with continuous gastric pH monitoring. So what they did was they took all these surgical patients and they started looking in at the gastric pH hour by hour and then giving antacids to keep the pH greater than 4. So if the pH fell below 4, some studies even cited 3.5, they would provide this antacid to bring the pH back up, become more alkaline. Then in the 1980s, we started using H2 receptor antagonists. So we really started doing that about twice a day at that point. And then there was a study that came out later that said maybe we should be doing this continuously because maybe we're not getting the same effect and we're not keeping the gastric pH at this more alkaline level throughout the day. So then it was becoming a continuous infusion. Then later, studies started comparing antacids versus sucralfate versus the H2 receptor antagonists, and that's a whole nother lecture in and of itself, which should be used and which shouldn't. But we were kind of using multiple different strategies to prevent ulcers. And then, of course, proton pump inhibitors came onto the scene, and now that's essentially what everybody uses. Very few people use sucralfate or antacids, and very, very few people are using the H2 receptor antagonist for critical care prophylaxis. So, first question we need to answer, is stress ulcer prophylaxis better than nothing? I think we should answer that before we start talking about critically ill patients. So, in 1978, NEJM published this trial of 100 critically ill patients, and their groups included a prophylaxis group of 51 patients and a no prophylaxis or control group of 49 patients. And what they found was that the incidence of GI bleeding really was improved in the patients that received the prophylaxis. Now, they were giving antacids at this point, I should just mention. 2 of 51 patients in the prophylaxis group had bleeding versus 12 of 49 of the control patients. So it's a pretty significant difference. Now, even though this is a small study, most of the studies back then were quite small. So I don't have much more data from larger studies at this point, but I think this does still prove our point that, that this was significant to show that there was a benefit. And then again, in 1987, there was a review. It was published in the Annals of Internal Medicine, and it looked at 16 trials, so the total number of participants was about 2,000, and they looked at both H2 receptor antagonists and antacids, and what they wanted to know was this helpful in preventing overt GI bleeding? So not just bleeding that was insignificant, but would actually cause a mortality for the patients. So the bleeding incidence in these groups are listed here, and in the antacid group, it was 3.3%, cimetidine was 2.7%, and those who got nothing, it was 15%. So the difference between 15% and 2 or 3% is quite big. So what's the answer to our question? Is stress ulcer prophylaxis better than placebo? And I think the answer is yes. So then now our second question. Should all patients critically ill patients receive prophylaxis. So this study, this 1994 NEJM study, was done by Dr. Cook and several other physicians. And they looked, this is actually the only large study that I found to answer our question. So they had about 2,200 patients, and they, again, used a prophylaxis group and a control group. The reason that the numbers between prophylaxis and control are so different is because they didn't randomize to either group. What they did was they basically said, okay, physicians that are taking care of these patients, I'm going to let you decide which patients you think need to receive prophylaxis. And there were certain groups that they said required it, such as burns patients, patients with spinal cord injuries. They excluded patients who came in with GI bleeding, but there were certain things that required it. So in the study, they had 674 in the prophylaxis group and 1,500 in the control group. And the goal was basically to show that prophylaxis for stress ulcers in these patients could actually be determined by the risk of bleeding and the risk factors that these patients had. I brought up these charts because I want to show you a couple things. So on the left side, this number circled in red, 8.4, this is a chart that's showing the patient groups with their risk factors that they determined, and then how many of those patients bled. So percent of those patients that had bleeding. So I'll just read off a couple of these things to highlight that. So in the patients altogether, patients who had respiratory failure and coagulopathy were the ones that were noted to be independent risk factors for bleeding. And so what the reason why that was determined was on the right side, they showed all these risk factors and they looked at an odds ratio of your risk of bleeding. Now, respiratory failure had an odds ratio of 25.5. Coagulopathy had an odds ratio of 9.5. After that, the odds ratio fell to 5.0 for hypotension and sepsis, hepatic failure, renal failure, enteral feeding, steroids, transplant, anticoagulation therapy. All those are also included as risk factors. But the odds ratio was so much higher in these two groups of respiratory failure, which was mechanical ventilation for 48 hours or more, or coagulopathy, which is an INR of more than 2, or a platelet count of less than 50. Those, by far, had a far greater bleeding risk. And when they used multiple regression to look at it, the odds ratio and p-value were statistically more significant in those two groups. So those were determined as independent risk factors of bleeding. And then looking at all these patients together and the percent that had bleeding, if you had respiratory failure, 2% of these patients had bleeding. Coagulopathy, 0.5%. But if you had both respiratory failure and coagulopathy, the percent that had bleeding in the patients overall was 8.4%. So those two combined are a much higher risk than either one alone. So this is just a quick slide to show why they think that is, at least for mechanical ventilation. So a higher PEEP from the ventilation itself can decrease your cardiac output. Then, of course, you have the pro-inflammatory cytokines that we talked about. You might have sympathetic activation from stress, from hypotension, increased catecholamines. All of this leads to splanchnic hypoperfusion, which is what we mentioned as part of our pathophysiology. So the important findings from this study was a small number of patients actually had clinically important bleeding. So it's important to know that this doesn't happen in a lot of patients. It's only 1.5% of their total number of patients. However, the mortality associated with this bleeding is 48.5%. So even though it's a small number of patients, the mortality is huge. So in the high-risk patients, those who had either respiratory failure or the coagulopathy are two independent risk factors, 3.7% had clinically important bleeding. Now in the low-risk group, people who had neither, the risk of bleeding or the incidence of bleeding was only 0.1. So the difference in the incidence between those two groups we see again, 0.1 versus 3%. So what that means, in their study, they did a really elegant job of stating this. Low-risk patients had a very low risk of bleeding, only 0.1%. So if none of these patients received prophylaxis, you might estimate the amount of bleeding to increase by twice, meaning the number needed to treat, they estimate it to be over 900 patients in the low-risk group just to prevent one clinically important bleeding episode. So you're going to treat 900 patients and only prevent one bleeding episode. So if you apply that to the high-risk group, if none of those patients received prophylaxis, again, twice the amount of bleeding, but the number needed to treat here is 30. So you treat 30 people and you prevent one clinically important bleeding episode. I think that is significant for us because I think that's a big enough mortality benefit and a small enough number needed to treat to make it easy for us to decide who needs to be treated. So we're going to summarize. Stress ulcers are caused by a combination of ischemia and oxidative stress. Clinically significant bleeding from stress ulcers carries a high mortality rate, as high as 48% is what we saw in that study. Prophylaxis of these stress ulcers has been shown to decrease the incidence of bleeding. Those were those 1978 studies. And then certain risk factors significantly increase the risk of bleeding, respiratory failure and coagulopathy. But those patients who do not have those risk factors have a very low incidence of bleeding, 0.1%. These are my references. And thank you. Any questions?
Any questions?
So the question is this slide incorporating those patients who did receive prophylaxis and those as well as those who didn't? Right. Correct. Right, so this is all patients. This is all comers. So they did sort this out into patients in the high-risk group and the low-risk group, into those who received prophylaxis and not within those groups, and then looked at the incidence of bleeding. And I didn't mention it here, but they mentioned in the discussion that the incidence for the high-risk group in those that received prophylaxis was still higher in bleeding than those in the low-risk group. So if you look at all the people that received prophylaxis, and between those, your control and your high-risk and low-risk, you still had more bleeding in the high-risk group, even though they were on prophylaxis. But what they kind of attributed that to was your risk of bleeding is so much higher, and also that there were more people on prophylaxis in the study overall, or not overall, excuse me, and the patients that had risk factors. So that included hypotension, that included renal failure, liver failure, all the things we mentioned, but particularly respiratory failure and coagulopathy. And they determined that the significance of it was that we as physicians were already deciding ourselves that these patients were at a higher risk. So we were deciding to put those patients on prophylaxis. So, I mean, yes, this data incorporates all of them, but that was the significance that they came to from what they got. So Dr. Bookspan's question was there information on how many patients or how many people had prophylaxis stopped after the risk was over? And I did not in these studies. There were some other articles, newer articles that mentioned it. I didn't really look into it as much because it kind of strayed away from our myth a little bit, but there are some, and I did in particular find a recent small study was published out of Australia that mentioned the overuse of prophylaxis once patients are discharged from the ICU, and I don't want to quote you numbers because I don't remember exactly, but I think it was as high as like 30 or 40% of those patients were still on prophylaxis after going from ICU to the wards, and then a certain percentage was discharged on it with no prior indication and no, this is a stress ulcer, not a peptic ulcer disease.
So I guess it's time to vote. So it's common that virtually all critically ill patients in the ICU get stress ulcer prophylaxis. It's something that's been generally pretty well accepted for many years. And I think the older physicians in the audience probably remember giving hourly antacids and checking pHs and things back in the day. So we've been doing this for a long time. The question is, should we be doing prophylaxis in all of these patients or not? So let's vote. So how many people think that we should be doing this in all critically ill patients? Okay. 2. How many people think it's plausible that maybe we should be doing it in all critically ill patients? Another couple. And how many think that this is a myth and this is just busted? That's pretty overwhelming. So, gotta have this, you know.